Okay, so let's start. I welcome you all today in the part 3 introductory session. I am really delighted and happy to see all the students who has passed part 2 and joining today. So I want to congratulate once again all the students, Dr. Akriti, Dr. Aarti, Dr. Farheen, Dr. Mariam, Dr. Revti, Dr. Rupa, Dr. Shobna. Really my blood has become 4 times after seeing all the success. Believe me, the part 2 is the biggest and the biggest effort. Now you must be feeling how you all are feeling. Are you feeling light? Are you feeling that the big burden of part 2 is off from your brain now? What do you all feel now after passing part 2? Yes, Dr. Shobna, Dr. Revti, Dr. Rupa, Dr. Anam, Dr. Farheen, Dr. P. I cannot understand the name. Dr. Priyadarshini, maybe? You all can open your mic and share your experience, how light you're feeling after giving part 2. Believe me,
Dr.
I am feeling
Shweta.
very light after seeing the result.
I'm so sorry. My name got partially typed. My system was not taking the name. Yeah, I'm Dr. Priyadarshini. Hello, everyone, and congrats to all of us for this.
Yes, yes.
We hurdle we
We
cleared.
have done it. It is like we should pat our back 100 times that we have done it. Believe me, it's so much to read, so much to retain, so much to do. Make notes, do questions. Part 3 is comparatively much easier. Believe me. That is the biggest thing. First of all, we have to understand that part 3 is much easier than part 2. So first of all, we should pat our back that we have finished the biggest hurdle of crossed the biggest hurdle to become MRCOG. And after part 3, you will get your degree, you have to go to convocation, you enjoy, you relish your success, and you really feel really good about all the effort you have put in this long journey. Because it's a long journey. Yes, it's a long journey for everybody because anyways, it is in 3 parts. So the earliest possible, even if you want to do, at least it will be 1.5 years. So it's a long journey, and you're putting day in, day out your effort, you're compromising on your pleasure things, your family, and you're putting your effort. And now the fruit is here. You all succeeded. So I'm really happy for all of you. And I really want to congratulate. And I want you people to pat your back and be happy about the God has helped you and you succeeded. Your hard work has been answered, your prayers has been answered, so you should be really grateful about this. And definitely part 3 is much easier, believe me, and you people will understand that yes, we have done the hardest, we have done the part 2, so part 3 will not going to be difficult. What do you all feel? What do you all feel that part 2 you finished, you're happy about it, you feel you're light now, the burden is over now? What do you feel?
Yes, ma'am. Really, it was a very
I'm
tough
yes.
time for me. I just gave up.
Yes,
I just decided not to give it again if I fail. It was my
yeah,
third
that's
time,
true.
and I took the course just because of you. Because previously I never attended any course, and it was my first course, and that's why I was waiting for your part 3 class.
No, thankfully, as I told you, part 3 is going to be much easier. You will enjoy it. And part 2 definitely will be with you whole your life. If you keep in touch of guidelines, it will, even after becoming MRCOG, if you move to UK, well and good. If you don't move to UK also, the knowledge will be with you. So that is the biggest advantage, that the knowledge never go anywhere and it makes you more confident and a better clinician. So how many of you are planning to give in November?
I'm
Not now,
planning to
madam.
give in November.
Ma'am, me
Okay,
too. I'm also planning to give in
okay,
November.
very good. And so Rupa and Revti planning to give in November. Shobna also, very good. So that's a good decision. To give in November also is a good decision. And if you have some commitments during this time and you want to give in January, that is also a good decision. Whatever you decide, it's good. One more question I want to ask. How many of you are practicing clinician? Means you are seeing the patient in OPD.
Yes, I am working as a
That's
consultant
great,
in
Mariam. That's
Pakistan.
great. Yes, Fareen, you are practicing. You are seeing the patient in clinic. Shobna is seeing the patient in clinic. Very good. What about others? Are you seeing the patient in clinic? Why I'm asking you is that makes things easier for you, not because you cannot talk to the patient. You can. It's only about, are you talking to the patient? I'm not telling about seeing particular field of patient, like are you dealing with obstetric antenatal patient or gynae patient or anything. Are you all seeing the patient really makes a difference? Why? Because you are routinely you are talking to the patient, so it's not difficult for you all to talk to the patient. Basically, part 3 is about communication, how you communicate with the patient, how kind you are, how empathetic you are. So it's not the test of your knowledge. Okay, even if you are seeing the patient in emergency room, you are seeing the patient in your clinics, if you are working, what I mean to ask by this is, if you are working, it makes your life easier because you are doing that anyways in your clinics, in your emergency room, in your labor room, anywhere. So the same thing you have to put in a more organized and in an RCOG manner, as we discussed in part 2 also, that you have to do things how RCOG like, how they do. So we have to go in their mode, and we first of all we have to accept their way, then only we can do it in their way. And as this is an English exam, so some of you might be mode of communication might be different. Some of you might be communicating in Hindi, in English, in your local language or whatsoever. So the other important thing is we have to communicate in English. So yes, if we are talking to the patient daily, day in, day out, it makes our life much, much easier. Okay, so this is me. This is me, your mentor. Most of you know me, Shweta. My name is Shweta, and I am the course director of MRCOG. And we have started part 1, 2, 3, all the courses now. So we are starting from the beginning and taking you till the end. I started with only part 2 in the beginning because first I wanted to do the hardest. So I did part 2 first, and students were really happy about it. And I think you all have given me a wonderful feedback also, which all I have put in website, and I'm very grateful for your words. And it really, really felt my hard work has been worked for you all, because almost a year I put in an effort for you all, making slides and all that things, and I think it helped all of you, and all of you really took it well, and your hard work has been answered. So now I'm in UK, Barts NHS Trust, London. It's a very good hospital, very good setup. Yes, my dear, right, Revti, thank you so much. Thank you so much for your feedbacks. Really, it was overwhelming. It was really like my sisters are talking to me. It's I always take my student as family, so it was really overwhelming. Thank you so much. So I'm now in Barts. How many of you are planning to relocate to UK after MRCOG? Because I can guide you in that perspective also. Rupa is planning. Very good.
I'm planning. I'm also planning, ma'am, to relocate to UK.
Very good, Anam. You are planning, and uh, who else told? Revti also planning. Farheen, you are also planning. Mariam, Farheen. Okay, even if you're planning to move to UK or you are not planning to move to UK, it doesn't make a difference. Definitely, this degree is going to give you credentials in your own country also. But the people who are planning to move to UK, one message I want to give today is, now there is a lot of vacancies in UK. Now there is a lot of vacancy going on because of the separation from Europe, and UK is separated. So lot of vacancies are there. So whoever is planning to UK, it's a very good time. So once you finish your MRCOG degree, which you will be finishing sooner, after that you have to do your GMC registration, and once you are registered with GMC, you can apply for the job through different job sites are there. You can directly apply in NHS jobs, track jobs. There are many ways. So we will talk about that in a separate session, that how to get into UK, how to apply for job after we succeed in part 3. For all the student, I will definitely do one session for that. And believe me, it's easier. And believe me, once I'm here, I even people are asking now. I have come hardly only 3 weeks. I have joined the hospital, and people are asking me, any of your friends are there who want to come to UK, who want to join, like that. So it's easy when somebody is here. From here, they can guide you. It's very, very easy. For me, there was nobody to tell me where to apply, what to do. So I applied many places, and finally I got 3 calls from London, and all 3 interview I succeeded. So interviews are not difficult. Don't worry about all that. So we will discuss about that after part 3. This was just for people who are planning to relocate to UK. to give them a hope that it's not difficult. And don't worry, I'm there always to help you all to move here, and I can definitely guide you. And definitely by the time 3 months down the line, I'll be more knowing about where all vacancies are there, and even in my hospital if there is vacancy I can recommend. So that all way it will be much easier for you people to relocate. And believe me, once you come here you will be really happy, though it is busy. But as we all are hardworking and we are busy practitioners, still we like it. So you all will enjoy your life here, don't worry. Okay, so this is my photo. Third day of my orientation. I thought I should take one photo. I should feel little happy. Though I felt like I went 15 years back because I started my residency 15 years back. So I felt like that I am again starting like that. But yes, it was a very good feeling because I could see whatever I am reading. I'm seeing that in front of my eyes. So it's a wonderful feeling. Okay, so what is our agenda today? Today we are here to discuss how to get through part 3 in first attempt. And believe me, it's easy. It's much easier than part 2. Again and again, I'm telling you because you have already done part 2. So it's not difficult. So take it light, be calm, be confident is very important for this exam, because this is a talking exam. If you fumble, they think that you are not a confident practitioner. So the more you feel yourself light and calm and composed, the easier this exam to crack. There's no rocket science behind this. This is only communication. They are not judging you for knowledge. They have already judged you for knowledge in part 2. So keep that in mind. So most important thing, how to start preparing. You all must be thinking how to start preparing. What should I read? How to start? So yes, you need a little bit of guidance that how exam goes, how to start preparing, what to prepare, what to read. Do I have to read the guidelines again? No. So don't worry. You don't have to go all the charts, whatever you have marked up for part 2. No need of all that now. So you can be relaxed. It is just a communication exam and they are judging you for how kind and empathetic you are. So it's not difficult. I will let you know how to start preparing and how to do it, how to organize yourself. Don't get confused by seeing here and there tits and bits. Some people will escalate things, some people will. I never believe in escalating things. I always try to give you, see, in any exam in part 2 also, my sentence was you don't have to score 100%. So don't worry, just relax, just chill. The same way I tell for part 3 also, you don't have to score 100%. So everybody will try to make you perfect. Every mentor will tell you this has to be done, that has to be done, this is important, that is important. Yes, that is important. But when you practice for part 3, you will understand. When you see, you will understand that every time you practice, something else come out of your mind, because this is not something you have to read and write. This is something reflexly come out of your mind. So we have to work on that. We have to organize ourselves that every time the same things come out of our mind. That is the thing we have to work upon. So it's little difficult, in the beginning. You have to set an agenda, you have to set a history format for you, and you keep practicing it. But still at the end, uh, something else will come out of your mind, something else will come out of your mouth. But believe me, it's acceptable. They also understand this is a talking exam. They also understand you are overseas candidate. So don't worry, it's not difficult. What material to follow, we will discuss that. How to set the right timelines. As I told you, even 3 months is fine for people who are in hurry to go, who are in hurry to do things. 3 months are enough because you are fresh from part 2, or your knowledge is fresh. So if you want to give part 3 only, you have to focus on communication, because structure viva thing you can handle well because already your knowledge is fresh. So don't worry about that. We can set the right timelines and work upon it. History taking is very important and it's key to success. So we will discuss about that. How to succeed in first attempt. It's not, as I told you, it's not a difficult one. And again, congratulations, congratulations, and congratulations. You have done part 2. So definitely you can do part 3 in first attempt. So it's not like part 2 where you are not sure of your success. Even me, even I passed all my part 1, 2, 3 in first attempt. But for part 2, I was not sure that I will pass. So you are never sure about part 2, but in part 3, if you didn't lose your composure, you after exam you can understand that yes, I'm going to pass. So that's the good thing about part 3. Okay, so what is exactly part 3 exam? Part 3 exam is a clinical assessment of knowledge, skills, attitude, and competencies. So yes, your knowledge will be judged. In structure viva, mainly they will be discussing things and all. Like we have given our viva in post graduation exam and things like that. So structure viva, the four structure viva will be there, where they might be asking you something like vulval cancer, something like for me it was VIN, vulval intraepithelial neoplasia. So that all structure fiber things are not difficult because we have already read enough for that, and they are not expecting there for you to give the percentage and things. So it's easier. Now the good thing is you don't have to remember any percentage. That is the best thing about the part 3, that you don't have to remember much, only you have to know how to communicate, how to comfort the patient is what they are. uh, your attitude, how kind you are, how much pauses you are taking when you're talking to the patient. Basically here, like sometimes we are talking too much short and too much in hurry. Sometimes we talk very short and concise, but here they always believe in too much counseling. So it will start from A and end to Z, so it will take too much time of your here in talking to the patient. Believe me, one patient seeing means I will take half an hour at least, because I will first talk to the patient, I will counsel her, then I will check her file, then I will make her note, then I will again talk to her if she has any questions, and then she will go, I will ask her, are you all right with following up here and there or whatsoever. So you always have to take their permission, you always have to communicate two way. They have to respond. It is not like you need to do this, it is like you have to give them options and they will choose, and then you will tell at the end, are you happy about doing this. So that kind of some simple words, simple sentences is what we need for this exam. And you can make a format like make 4 5 sentences and keep it with you and always use that, because every station is different. So don't think that how can I repeat one sentence. The same sentence you have to repeat in each station. You fix your line, which line suits you, because everybody's talking way is different. So for some person one sentence feels good, for some person the other sentence feel good. So I'll be giving you 2 3 sentences for anything, asking anything, and then you can choose one which suits you, which you feel you can speak, and then you have to practice that according to your convenience. So that's how the talking things goes here. So they are judging you for that. And as after this you can get the degree, and then you can move to UK if you want to. You can do higher training here in UK, you become ST6 and 7. So this is a, after passing part 3 you become ST6 and 7. So once you do MRCOG, you join here as an ST3. You can join anywhere, ST3, 4, 5, 6. There is nothing, no like separation. They take you as a registrar, which is a middle grade doctor, which is from ST3 to 7. Whatever your competencies are, accordingly you will be ultimately graded as a middle grade doctor. That's it. So because you are overseas candidate, so it doesn't make a difference. Ultimately everybody are doing same, either they are ST3 or 6 or 7. All are doing the same work, covering the labor room, doing the ORs, and they allow you to do things, surgeries. And it's not like somebody asked me that in UK they don't allow you to do anything. It's not like that, believe me. I'm here only 3 weeks old. I have done one placenta previa, I have done one abruption, I have done previous 2 CS bad addition. So it's not like they judge you, it's not like they don't tell you you can't do this, you can't do that. If you can do, they will allow you to do, and they will be there to support you. So don't think that some people told me that in once you come to UK your hand get rusted because they don't allow you to do anything. It's not like that, believe me. Any country you go, they allow you to do what you know. So don't worry. And here, because it's a teaching institute, the seniors always like to allow the juniors to do things, and they like them to do things. So it's not like that. You'll be happy if you are planning to relocate, you'll be happy. Now, how the exam goes. It has 14 tasks in a circuit. Why it is called a circuit? Because it is in a circle. Still, I remember the exam. It starts from one station, whichever station, either 3, 4, whatever number you start, and then it will finish at the next number. So total, it will be in a circle. That's why circuit, and it's a 14 task station. So 14 tasks will be there, which you have to cover, and each task will be based on 14 module. Now, if you see 14 task domain, so you might not be aware of all these words, domain, signposting, and duty of condor, what all these words are. This we have never heard of in part 2. So that are specifically designed for part 3. That's why you have not heard. Don't worry, it's not a very big thing. It's it's five domain which you have to cover, but in every task you don't have to cover all five domain. So module have five domain like patient safety, very, very important. And patient safety has the maximum marks. That's why patient safety is very, very important. So what does it mean by patient safety? When I was reading, I will tell you, I was thinking every whatever station I would use to solve, whatever template I used to make, at the end I used to think, what are the safety point in this? So safety could be anything. Patient safety means like uh, asking for allergy before giving antibiotic. This is a safety point. You always have to ask for allergy before giving antibiotics, isn't it? So that's a safety. If you are a safe doctor, you will do that. If you will forget that, means you are an unsafe doctor. Why you'll be an unsafe doctor? Because if you will give her the antibiotic she's allergic to, she will get reaction. So that means you have not done enough. So safety in that terms, whenever you are prescribing a medicine, you have to ask for allergy. Safety in terms of escalating things. Like you have seen in urogynecology, it is MDT. In sepsis, sometime it is MDT. So whenever you see a patient which you need to liaise with somebody else, you have to talk to some other specialty, you have to talk to somebody else, you should always do that. So sometime communication with colleague or escalation that you have to do, safety is very, very important. So patient safety, as I told you, is really, really important. And when we will discuss the modules and templates, we will keep discussing about patient safety points so that you will never forget. And gradually you will automatically understand. Like a preterm. For a preterm, if you don't inform the neonate, if you don't confirm that ICU is there or not, that is a patient safety, isn't it? If you don't confirm the ICU, you deliver the baby. You might have required to do in utero transfer for the baby, and you have not done that. So that means you are an unsafe doctor. So safety is not always about your management. Safety is about uh, doing it in a right way. Whenever you have a preterm, you have to inform the neonatal, inform the ICU if there is place in ICU or not. So these are the safety point. Whenever prescribing drug, asking for allergy is a safety point. Escalating the matter to other specialty when needed is a safety point. So this is a different aspect of safety. And as I told you, safety has the maximum number of marks. If you pass in safety, you have passed that station. Think like that. Then the communication with patient. Communication with patient means history taking. You talk to the patient first to take the history. So that is communication with the patient, isn't it? History taking, and then in between you are explaining to the patient whatever. So that is communication with the patient. Very important aspect of communication with the patient is listening. Allow the patient to talk. What happens? Because see, this is a bit of acting exam, you should know how to act also well. So if you have done little bit of theater in your school and all, you will be easy on this. Though you have to think that the role player is a patient, but still a bit of acting is required. So communication with patient is very, very important. If you allow the patient to talk, means the role player to talk, it becomes easier because they direct you in right direction. In our mind there will be 100 things, but in role player mind only one thing is there, that this point and they are helping you, believe me. They are not your enemy, they want to help you. So if you forget something, they will bring you back to the point where you will score the marks. So allow the role player to talk. You talk less and allow the role player to direct you in the right direction, because they know you have the knowledge, but you have to produce that in 10 minutes. It's not always the perfect assessment. Sometimes you know the things, but you cannot produce it in the right way in 10 minutes, isn't it? So communication with patient means the main thing is give role player to talk, time to talk. You talk less, allow her to talk more. Open questions to the role play, that all we'll discuss. So that will help in better communication with patient and easier and taking you in the right direction. Then comes the communication with colleague. As I told you, lies with other colleague. Like if you have to, sometimes you have to contact the ICU specialist, critical care team. Sometimes you have to ask to the infertility specialist, urogynecologist, in oncology, oncologist. So that is a communication with colleague. So it's important. You always have to talk. Informing your consultant anything is also communication with colleague. The consultant is also colleague, isn't it? So if you find any complicated thing, I will escalate the matter. I will take opinion of my consultant. If you say, they will be happy about that, because you don't know everything. Nobody knows everything. So don't feel offended in communicating or taking advice from the seniors. So it's a good idea to work in a team. So communication with colleague means that. Information gathering, again, information gathering will always be there in any station. Information gathering will be there because you have to talk to the patient, you have to take the history, you have to gather the information either from the patient or through the leaflets accordingly. So information gathering will always be there. Applied clinical knowledge. Now, applied clinical knowledge is your part two knowledge. Like if you have to manage HMB, so you will tell her what all options she has. First and foremost, first line treatment is Mirena, and these are your option, non-hormonal, and this and that, and then endometrial ablation, then hysterectomy, whatever. So all the options you have to talk. You will not tell that because you have HMB and Mirena is the first choice, I will put Mirena for you. No, you know everything, but here you are not the choice maker. The patient is the one who is going to choose what treatment she wants. So this is very important, because in our clinical practice, what we do, and our patients are also like that. If you tell them three things, they will tell, oh, doctor, you tell me what is best for me. But here it is not like that. If you give them three options, they will come out with one what they like. Here they will not tell you, you tell me what is best. No, they will take their decision, they will take responsibility for their decision, because whatever they will choose, the side effect of that will be their responsibility. So that's how things work here. That is the difference in our practice. If I talk to my HMB patient, I will tell her, okay, fine, you want contraception also and this that, okay, fine, so oral contraceptive pills I will be prescribing you, like that, like that. I don't have to counsel her that there are 5 modality of treatment. I can simply prescribe her what I feel is right for her. Sometimes if the patient doesn't ask for, is there is any another option, or if I want to give something and she tells, no, I'm not going to accept this, then I will tell her these are the other options. But in UK, you have to understand that it's always about giving the choice to the patient, and they are the one who are going to decide. They are the decider. So this is very, very important in applied clinical knowledge, to give them the choices, and then finally they will come up with the right thing, whatever suits them. There's nothing right or wrong. These are all treatment modality. Whatever suits them, they will choose it. Okay, so how is the marking done? You have to perform each domain to reach the cutoff. What is the cutoff basically? The cutoff is not fixed, the same like part 2. It depends upon how other student did. It's the average, the same. It is the norm-based exam. So how other, because the difficulty of station will be different every day. There are 3 days exam. So every day the stations are different, and every day the students who are taking the exam are different. So according to the level of difficulty of station, whatever that day the students has performed, accordingly the average will be taken out, and then you will be passing the exam. So there is no fixed percentage, the same like part 2. You don't have to pass individually in each domain. That is a good thing, that if you score patient safety 2, and if you score information gathering 1, the patient safety 2 and information gathering will compensate for each other. So all in all, you have to score a certain points, but not necessarily that if one domain you get fail 0, it doesn't matter if you have compensated it by other domain. So like supposedly 5 domain they are asking, and each passing is 2. So supposedly 2 marks, you have to total score 10 marks are there, right? And maybe other students are, the maximum marks scored is 7. So even if you have scored 5 in that station, you are passed. So like that. So each domain separately, they are not going to judge. They will judge total how much you have scored in that station, and accordingly they will declare you pass. Okay, so now what are these tasks? We saw that there will be some domains. We saw that these will be the 5 domains which you have to cover. Sometimes there will be 3, sometimes there will be 4, sometimes it will be 5 also. But always there will be information gathering, and safety is always there. So each task is 12 minutes in length. Okay, so each station will be 12 minutes, out of which 2 minutes will be the initial reading point. Means what happens, there is a cubicle and there is a curtain or something is there outside, or sometimes even if curtain is not there, they will put outside, there is a board sort of thing where they will stick the things. So they will just put by clips, sometimes they put muse chart. Believe me, in my part 3 exam, I got a Muse chart for a post-op patient. Uh, I have read about Muse chart. I have seen my Muse chart in my country and all that things. But at that time, when I saw the Muse chart, I cannot interpret anything. Means my mind is not working. So this exam is not about how much you know. This exam is about how much your presence of mind in that 10 minutes, how much your brain is used to take that much stress of approximately 3 hours. It will be total 168 minutes. 12 minutes each. So it will start and it will finish and you will not know only, but you have to move from one station to other, the other to other, and the exam is finished. So the most important aspect of passing this exam is keep your presence of mind, keep yourself calm, don't get blackouts in that 168 minutes. That is the most important aspect, believe me. It's not about how much you're prepared. Some people will tell you, oh, I was not at all prepared. I just took it as it is my clinic patient and I passed. So it's not about how much prepared you are. Yes, you have to have a basic preparation of talking to the patient, that this is how they talk and this are the some important thing, and RCOG mode, like support groups, like duty of candor and all that thing we will discuss. So that all things are there. So that little bit once you inculcate, it is all about how much you give your presence of mind in the exam, believe me. So the people who are practicing already talking to the patient, it is not difficult. Only take the role player as your patient. Think that she is your actual patient and allow her to talk, and she will direct you in the right direction and you'll pass the exam for sure. So it is all about, you shouldn't get nervous on that day. I always told you in part 2 that you should be calm, 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 but at least that is a writing exam and you have 3 minutes. If you get a blackout for 2 minutes, also you can regain. But here, if you get a blackout for 2 minutes, you have lost that station. So here you should really learn how to concentrate, how to keep calm, how to keep your composure and finish that 12, 14 station. Thankfully, in between there will be structure viva. So in between there will be total 10 role play tasks are there and 4 structure viva. So in structure viva, at least it is only the examiner is sitting and you are sitting. So you get a little relaxed because you don't have to do any acting there. So it's relaxed in between. You get relaxed and then you go to the next station like that. So whatever it is, from wherever it starts and wherever it ends, it doesn't matter. All in all, you have to keep your presence of mind in that exam time, and uh, you have to produce communication. So it's not difficult. This is what you have to keep in mind. Keep telling yourself, keep calm, I'll be fine, I'll be fine, like that. So this is very important, because panicking is not going to work, because this is personal physical presence exam. Previously it has been done online, but I think now it will be face to face only. So that way you have to keep calm is what the sole mantra of hitting this exam, believe me. Sometimes there is a lay examiner in the exam. Means what happened in this station, there will be one role player who is acting as a patient. There will be one examiner who is sitting to give you marks, and there will be sometimes 3 people in the cubicle. So the third person is the lay examiner. So lay examiner is a non-medical person. So why they're sitting there? Because they're judging your attitude, your body language, how you're talking to the patient, how kind you are, how you're taking pause. Supposedly, I will give you a common example. They give you a second stage patient and you have to counsel about breech delivery or something like that. And in between, the patient is instructed to do, that means she is getting contraction. So that means she's getting pain. So at that time, you shouldn't talk. You should stop talking, because anybody getting contraction, getting pain cannot understand what you're talking. This is a common sense, isn't it? But because we are in exam and we know she's an actor acting, sometimes you might miss it, the simple thing which we also do in our labor ward. Whenever a woman get contraction, we stop talking, and once her contraction is over, we talk to her. So these simple things, the lay examiner is the one who is looking for your attitude. The other example I will give you, IUFD or miscarriages, breaking bad news. The women will sit and she'll start crying. She'll start crying. What you will do? You don't know how to handle this, because she's an actor. But you think she's a patient. Your patient crying in front of you, what do? You console her. Don't worry, I know it is difficult for you, but I'm there to help you. You will hand over her one tissue to clean her tears. You show communication. You sometimes in our clinical practice we touch their hand just to make them feel better. So whatever way you like, you have to do, but you have to first console. Otherwise, she'll keep crying whole station and she will not talk to you, and you will lose all your marks. So that is how the role player are trained, and that is how the lay examiner are seeing how empathetic you are. If you being a patient, what you expect from your doctor to be a little kind to you, isn't it? If the doctor is just like prescribing you medication and sending you in 5 minutes, you think the doctor was rude. So in such scenario, you cannot pass that station. So you, even if you take time, even if you don't finish the station fully, it's okay. You can pass that station. Even if you have not covered till end, you can pass that station if you have done it in a right way. So doing things in a right way is main thing. Do things in a right way. Take pauses, no problem. You don't finish the station, no problem. But whatever you have done, if you have done in a correct way, you get the marks of attitude. You get the marks, especially in the lay examiner station. You understood that something is fishy here. I have to be extra kind. In lay examiner station, you understand if three people are sitting inside means you have to be extra kind and little slow, because they will give you the cues which you have to catch and accordingly you have to behave. So lay examiner stations are really more marks also, because the lay examiner will also give you marks. So it will be extra marks also, and extra kindness also is required for that station. Okay, so there is 14 modules. You all know this. I don't have to go through this. These are the 14 modules and there will be 14 stations. Some will be structure viva, like sometimes the oncology will be in structure viva, like it was for me. Oncology, one oncology was structure viva for me. I cannot remember all, but one was labor room scenario for was the structure viva for me. So it's not difficult. It's not difficult for sure. You can handle it. If you have handled part 2, you can handle part 3 for sure. Now, as I told you, there are simulated patient tasks, colleague tasks, or structured discussion tasks. 4 will be structured discussion, 10 will be simulated patient colleague tasks. Simulated patient means the role player, as I told you, they are actor, but you take it as they are patient, your own patient. Then only you will be able to do the justice to your role. Sometimes in simulated patient tasks, there is a colleague. How they give you, you are an ST5, and you are talking to your ST2. ST2 is your junior, right? ST1 to ST5. So ST2 is your junior. So you are talking to your junior, and then you have to teach her something. Like in my exam, it was PESRI for me, teaching PESRI insertion to my junior. I was ST5 and there was a male. There will be male actors also, okay? So don't think that it will only be female patient. So there will be, like colleagues can be male. So he was a male and he was ST2 and I have to teach him PESRI. I was knowing everything about pessary, but believe me, there was a prop in front of me. There was a prop in front of me. Pessary was in my hand, the ring pessary. I'm telling him that you have to put the pessary like this is the right way, these all things you have to check, this, that. But I know something is missing because that guy, the actor, he's not nodding. So I understood that something is missing. And then at the end, when I'm finishing the station, I understood that this prop is kept here. So I should put it inside and show him how to put. Talking doesn't work. I have to show him, demonstrate him. So whenever there is props, try to understand, use it as much as possible. Whenever there is props means, especially in teaching. In teaching, always use the props, whatever provided to you. Otherwise, you cannot gain the marks in that station. So providing the props is very important, means utilizing the props is important. When you're talking to patient also, if you make a diagram, you don't have to make a beautiful diagram, but making diagram, you get marks extra. So don't forget all these simple things which can score you extra mark. Like whenever I explain my patient PCOD in my clinic, I always draw a diagram, show them this is tube, this is ovary, your ovary is fat, there is multiple follicle, like that. So whatever you talk, it doesn't matter, in this exam. If you follow these small rules of how to make things better, like making a picture will make better understanding of patient, and you should make a picture the way that patient can see better than you, means it will be ulta for you. You will look at ulta, but patient can see it seedha. So patient can see it in a right way. So you are taking extra effort to make it more easier for patient, you get extra mark. So all these small things you have to understand in this, how to behave, how to behave in front of patient, how to behave in front of colleague. Like if you go to ST2, you will not tell I am Dr. Shweta. You will tell, hi, I'm Shweta. She is your colleague, she or he is your colleague. She's also doctor. No need of showing off saying that I actually here nobody use the word doctor. We to give respect to senior, how we use doctor some so and so, doctor so and so. Here nobody use doctor. They simply say, even when I introduce myself, I'm Shweta, one of the OB doctor here. I'm Shweta, one of the gynae doctor here, like that. So here nobody use doctor prefix most of the time. So when you go to your colleague, you'll simply say, I'm Shweta, one of the ST5, and today I'm here. Hi, like if you're talking to ST2, how you meet your colleague? Hi, how are you doing? How are you feeling today? Nice to meet you. Nice to see you here today. I'm here today to discuss with you about pessary insertion. Is that all right? How's your training going on? What are your future plans? So how you meet your colleague, the same way you have to behave, that you are meeting your colleague, you are happy. The happiness, showing the happiness is very important when you are meeting your colleague, especially. Sometimes some stations you have to show happiness, some station you have to keep calm, and some station you have to show sadness. Like breaking bad news, you have to be very, like, as if somebody has died. Like that kind of sadness you have to show. If you are meeting a young girl, a 14-year-old, you have to be very chirpy. Means you have to fit into her shoes, otherwise she will not explore. You cannot explore her concern. So when you are meeting a 14-year-old girl, you have to be really, really chirpy. Hi, how are you doing? How's your school going? And how can I help you today? Like that. So it's a lot of fancy things, which simple things, though it is simple, but if you don't do this, marks are cut. So it's important. So this is what you have to inculcate, not the knowledge, not nothing. Only you have to inculcate this kind of behavior and talking sense, which for different uh, different type of your patient, you have to mold your voice, mold your verbal cues, mold your body language. This is what is needed for this exam, and that's how you pass the exam. Not by what you're saying, but if you are doing it in a right way, you pass the exam. So that is the main thing. Because the role player, they are already instructed that if they will not ask you empathetically, don't speak. Like I told you, if somebody's keep crying, you don't offer her tissue, you don't console her, the whole station, she'll keep crying. And you will not understand why this lady is doing so much of acting. But she'll keep crying because she's instructed like that, that if this doctor is not going to ask you sympathetically, don't answer. Somebody will keep her head down, and she will not raise her head only. So up till her expectation, you have consoled her, she will not speak to you. So that are some of the things they want to. You will enjoy the acting, don't worry. It is not difficult, you will understand it. Okay, so to summarize, there will be a circuit, there will be 14 station, 2 minutes of reading time you will get outside the cubicle, and then you will enter the cubicle, and 10 minutes of performance. So 2 minutes of priming before the acting and 10 minutes of acting is what you need. So 10 minutes is not big. In 10 minutes, you cannot give anybody any knowledge, believe me. 10 minutes is not big. So don't think that I have to mug up the guideline again. No, no need of all that. Whatever you know, whatever first come in your mind, like if I talk to you about sickle cell anemia, whatever come to your mind first, like UTI, like she has chance of sickle cell crisis, 2 3 points will pop up in your mind immediately. She need folic acid, and these things come in your mind, right? So that much is enough to cover that station. You don't have to know every tits and bits of sickle cell anemia guideline. 3 main points, if you know, enough, you can pass the station. And sometimes in anxiety and too much, because your brain has to continuously work for 168 minutes, sometimes you might forget some things, but that is acceptable, as I told you, because you don't have to score 100%. So don't worry about that, and don't carry the baggage to the next station. That is very important. As I always tell you, don't carry the baggage. Whatever happened in that station, leave it there and go to the next station fresh. So take it as a challenge. And the circuit is really challenging because you have to perform continuously. You don't get any break. But you can do it because, as I told you, it starts and it finishes, you don't get to know. It start and you start performing, and once it finish, you take a deep breath. Oh God, it's over. It is like that. So you don't get any time to feel about sad or about previous station or happy about any station, you just keep doing it and finish it off. So there will be role play station, which is also known as simulated patient task, and there will be structured discussion, as I told you, and there will be lay examiner in some, which are the station to be extra kind and extra soft to the patient. Okay, so if you see November exam timeline, till now this is only available for February, they have not declared. So you have to send the assessment of training deadline by 8th of August. I hope you all have sent. And then the booking token, they will send all these to be confirmed. So still no dates, but yes, keep an eye on the dates so that accordingly you can book your exam. But nowadays the exam fee is really, really costly. You know, when I gave exam, I think it was 600 or something. Now it is 800 something. So it's really getting more and more costly nowadays. So give the exam when you're prepared. This is what my message is. Give the exam when you're prepared, and it doesn't require much of preparation, but give the exam when you think you can handle all the 14 stations with calmness. This is what the requirement is. There is no requirement of reading and getting, you know, mastering in guideline, which you have already done, and which is enough. So it's only gross point you have to remember, which you will talk to any patient. Like in maternal medicine, you talk gross point to the patient. The same thing is required. They are not going to ask you detail of anything. So that's a good thing. Okay, so what you will do outside the cubicle, what you will do inside the cubicle is very, very important. So outside the cubicle, most important is be calm. Gather as much information you can gather and write it. They give you a pen and paper, means a pencil and a notepad they give you. So what you have to do, supposedly, like I told you, there was a Muse chart for one patient outside. So I couldn't understand what to gather from that, you know. But once I came here, I understood how to read Muse, because it's not that difficult. If it is in red or not, you have to see. So when we discussed in the course, we will discuss how to read Muse chart, because always there will be one question, one station of Muse, either related to post-op patient or any patient. They will definitely give one Muse, because that is patient safety. So that's important how you read. Sometimes there will be 4-5 pages outside the cubicle. You cannot read it even in 2 minutes. You cannot understand, because suddenly moving from one station to other means you were talking about infertility, now you have an intrapartum. So your mind take a little bit time to move, isn't it? So that is what you have to learn, that how to move fast, how to leave that and engage from the another station, how to collect the information. So what you will do in that 2 minutes is just see whatever you can see grossly, what is the patient. Sometime outside it will be written that it is a GP referral letter. So they will write a GP referral letter for a Mirena insertion for HMB, or a GP referral letter for some particular thing like oncology, either pap smear is positive, CIN or whatever. So if there is a GP letter, then you have to always talk to the patient like, hello, I'm Shweta, one of the doctor in OB or gynae, whatever. And can I confirm your name? Always you have to confirm the identity of the patient. That is also a safety point, because you shouldn't talk wrong to a wrong patient. So asking the patient, asking here, everybody follow the date of birth. So date of birth and name is what they follow. So can I confirm your name and date of birth? What would you like me to call you? Like that. These are some prefix format, which once you fix for all the station, you will be using that. So then you will tell that from your GP letter, I understood that you have been sent for this and this. Am I right? So she will say you yes. Then you will tell that, okay, do you have any other concerns? Why you ask this? Because sometimes what happens, they trick you. The GP will write something like they have referred you for HMB or whatsoever counseling, but patient has some different agenda. Patient wants to talk about something different. So if you don't cater that aspect of patient, then you failed in that station. So always patient concern you should always ask. So that's an important thing. So I'll tell you the format, how to set your template and how to ask it. And once you do it, you will master it every other day and it will not be difficult. So these are the things. And once you tell her, okay, so as I understand, your GP has sent you here for heavy menstrual bleeding, because you are suffering from heavy menstrual bleeding, and you decided about Mirena and you want to put Mirena or something like that. Then at the end, when you finish that station, you have to tell that I will write back to your GP. Whenever you have received any letter for anybody, you have to write back to them. This is important. There is a marks for that. So whenever you got a communication, you have to communicate back. That is important. So this is how some simple things are there which we have to follow. And it's not difficult. Outside the cubicle, only whatever you can gather, it's fine. If you don't, there is inside on the table. It is a glass table, and all the things which are kept outside the cubicle are also kept inside on the glass table. So you can even see there, means you will note down some things. No need of writing the numbers that her creatinine is this much or this and that. No need. Only interpretation you have to write that her hemoglobin is all right. Supposedly all her blood investigation are normal. So no need of writing that in your notepad. Just write that her blood investigations are normal, or her temperature is high and all other things are normal, whatever. So your conclusion you have to write there. So accordingly you get to know that what counseling you have to go inside and do. And if you cannot read all the pages, even after going inside, you can tell that I couldn't finish the reading of the outside papers. So can I take a minute to read it? They will not stop you for that, but you will lose time for counseling and all that things. So try to get the conclusion of whatever is written outside. You don't have to go in detail of everything. Just try to get a conclusion. And even if you don't get the conclusion, don't worry. Inside people are sitting and trying to guide you. They will guide you and take you in the right direction. Allow them to talk. If you get a blackout sometime, if because it's a long exam, 3 hours approximately. So in between, if supposedly your mind is not working and you don't know how to handle it and you feel I'm giving away, don't feel like that. Just go inside, take help of the inside role play. You just ask her, can you tell me more about your problems? If you say that, this is the golden question. Can you tell me more about your problem? And she will take you in the right direction and you will start. So don't feel lost. Whenever you lost, the role player is there to guide you. Just tell her, can you tell me more? This is the golden rule. Can you tell me more about your problem? Always open question. Can you do you mind telling me about how you're feeling? Can do you mind telling me about your problem more? Like that. So this kind of open question really helps. Why it helps? Because then they tell you what points are going to give you marks. So they will only utter what is, because they are role player, they're actor, they don't know full HMB. They only know 3 sentences told to them, which they have to disclose if you ask in right way. So if you give an open question to the role player, she will automatically come up with the right things which you should focus upon, because she has the written script which she has to read. So that way, as I told you, whenever you feel lost, speak less and listen more. So that will be the key. But outside the cubicle, you have to note down and get whatever gather you can gather the information. But don't get worried in that scenario, because at the end, when you go inside, they are there to help you. Then inside the cubicle, how you will behave, you will introduce yourself. Why introduction is so important here? Because there are a lot many of doctors, like we are team of 40. So today somebody is seeing, tomorrow somebody else is seeing. Today I am in a MAU, tomorrow I am in a triage, day after tomorrow I am in labor room, other day I am in theater. So patient doesn't know me. Even people here are operating on somebody else's patient, means they have not seen them in clinic and they are operating on them. So you are fixed in gynae theater today, you will operate whatever is posted in that theater for whomsoever. So it's not like it is my patient and I'm going to operate, not like that. Like it was in our private, it is not like that. So you always have to introduce yourself that, like if you go inside the cubicle and there's a role player, you will tell, hello, I'm Shweta, one of the OB doctor today. How are you feeling today? Can I confirm your name, your date of birth, if it is given, or only name? What would you like me to tell you? And whatever she says, and then you will tell her, can you tell me more about your problem? Would you mind me asking some questions to you? It's always like you have to take her permission. Here it's very much taking the permission for everything. Would you mind if I ask you a few questions? Would you mind if I ask you a few personal questions? Like when you take sexual history. Would you mind if I ask you a few personal questions? Are you with someone presently? So you have to be extra nice and soft. Because if you are too much firm and confident and your voice is loud, usually whenever we are very confident, our voice become loud. So you have to practice being soft, because if you are loud, patient feel that you are rough. So you have to be really soft in talking to the patient. So always taking the permission to the patient that, can I ask you this? Would you mind? Like that. These kind of words you have to use. So this is the talking, the talking rules which you have to follow while talking to the patient, which we usually don't do with our patient. So that's the difference which we have to understand. How they talk, the same way we have to talk. So once you have introduced yourself that I'm Shweta, one of the OB doctor here, and as I understand, you are here to discuss about the management of whatsoever overactive bladder or whatsoever you're having overactive bladder. Could you tell me more about your problem? She'll tell you. Okay. So then you have to set the agenda. You have to tell her what all you're going to do in today's communication, because you're not going to operate her then and there, isn't it? So setting the agenda is important. You will tell her, okay, so what we will do today, I will take your history, then I will examine you. If examination finding not given there, you have to examine her. So I will examine you. Usually there is no examination, because most of the time it is only talking, because there's no place to examine. So most of the time there's no examination, but sometimes you might have to speak that I would like to examine you if needed. So I would like to take your history. Would word is very important. I would. It's not like I can, I will. No, I would. I would like to. I would like to examine you. I would like to ask you a few questions, take your history, then I would like to examine you. And then we will discuss the options, treatment options available for you. And then I will write back to your GP. How does that sound to you? Or would that be all right? So this is how they talk. Would that be all right? Means you are taking her permission that, are you okay with my agenda? This is what I'm going to do with you in next 10-15 minutes. Are you okay with that? She has to say yes. And then after setting your agenda, you will tell, uh, do you have any other concern you want me to discuss? This is important, because as I told you, sometimes there is something hidden. So do you have any other concern you want me to discuss today? So that's a good thing always to ask after setting your agenda. And then you will take her history. You will gather all the information. Always, whenever you finish the history, you have to signpost and go. Signposting is a word. Signpost means, thank you for sharing your information with me today. Now I would like to examine you, or now we will discuss about the treatment options available for you if examination not necessary, examination investigation not necessary. So you will tell, now I would like to discuss the treatment options available for you. Is that all right? So she will say yes. Then you will discuss the treatment option. Because sometimes what happened, patient will tell, no, it is too much to take in, like in IUFD station and all. Patient is already sad. She doesn't want to listen anything. But still you have to counsel her. So you have to keep taking her permission. That, shall I tell more or shall I stop? These kind of things are there. So whenever you are going from one step to other, you have finished the history and you are discussing now treatment option, you always have to tell her that I finished the history now. Thank you for sharing your information. Shall I go to the next step, which is examination or investigation or counseling about the treatments? So you always have to signpost, means you always have to tell her that I'm going to the next step. The other signposting is before breaking the bad news. You always have to tell her. You have to, like, rather than telling me something bad, like you have a cancer. If you tell me straight away you have a cancer, I will really feel very bad. It will come to me as a shock. But if you tell me, I don't have a good news for you, so her mind is already alert that something bad is coming. So you have to, two times you have to tell, I don't have a good news for you. Is there anybody today with you? Do you want me to call somebody to support you? Like that. So that time, that seconds you have given to her, her mind is prepared for the bad news, that bad news is coming. So they will tell, no, no, okay, go ahead, I'm ready to listen. Then you have to tell, I'm sorry, I don't have good news for you. Your report says that you have cervical. CIN is also a kind of bad news, but especially the cancers are bad news. IUFD miscarriages are bad news. So anything which required, like losing the baby, either it is miscarriage, and also it is a breaking bad news. So that's how you have to prepare her before breaking your bad news. So that's important. How to communicate, how to signpost, how to take breaks, how to ask in between, is that all right? If you tell her to do something like, if she's smoker, you will tell her, would you like me to refer you to stop smoking services? If she says yes, then only you will refer, okay, I will do that for you. Supposedly you want her to do something like follow up after 1 week for the report or trace the report or something. Will it be okay if you call for the report? Would you be able to do that? Is that okay for you? So that kind of sentences you have to keep telling in between. And once she give you the history also, you have to keep nodding, keep showing that you're listening. Though though mentally you are too much occupied with things, but when she tells you anything, like if she says that I'm pregnant, and then you ask, is it a planned pregnancy? And she says yes, you have to say her, oh, congratulations. So if you say congratulations, it is not going to work. Congratulations means your feeling didn't come out. So you are not telling it with happiness. So you have to really show happiness as if she's your sister. Oh, congratulations. I'm very happy for you. So if you say like that, you already gain the mark on your start is very good. So this simple things is what counts the maximum in communication. So this is how you score the marks. So information gathering, showing in between the cues like, oh, is it, oh, I can see it is difficult for you. Like if she, her emotion, like if you get an angry patient, you get an angry patient, like some mother or some daughter is angry, daughter is undergoing MTP and mother came to ask what is happening, this, that. You cannot disclose the information because this is confidentiality. So, but you have to understand she's angry and you have to agree with her angriness. You have to tell her, I can see you're very angry. I can see you're very angry, and if I would be in your place, I would have felt the same. So you are agreeing with her, then only she'll calm down. So don't tell her that your anger is unnecessary. Even if it is unnecessary or what, you have to show her that I agree with you, I agree with your anger, and I would have also felt the same. But unfortunately, I cannot disclose your daughter's information because of the confidentiality. I'm very sorry for that. So keep apologizing, no problem. Saying sorry doesn't mean that you have made a mistake. Saying sorry is for the situation. The situation is like that. You are angry, and I'm sorry for that, that I cannot help you. So saying sorry is not admitting the mistake, is what you have to keep in your mind, and keep saying sorry to come to make somebody calm. Like supposedly we go to some clinic and we are waiting long time. We are really pissed off with the situation. Hi, my dear Pogolu. We are really pissed off with the situation. And if somebody just come and say us, I'm sorry for your long waiting period, we feel better, isn't it? We feel better that at least somebody is acknowledging our pain. Somebody is acknowledging that we are suffering because of their whatever reason. Maybe they have a emergency or whatsoever, but that is not my problem. A doctor getting emergency is not a patient problem. Patient is scheduled at 3 o'clock and doctor coming at 3:30 because of emergency means it is not patient fault, it is doctor fault. So if somebody come and apologize to you, I'm sorry for this, you feel little better that at least somebody is saying sorry. So saying sorry is really, really like we tell our children, thank you and sorry is the magic words. The same way, saying sorry for angry patients, saying sorry for IUFD and miscarriages, I'm sorry for your loss. These kind of things are common and you have to speak like that. Check patient understanding. Am I clear? Whenever you tell her, like I'm telling somebody OAB treatment options or SUI treatment option or HMB treatment option, I have to ask, are you able to understand, or I will just keep going, keep going, keep going? No. First of all, I will be giving her the information in chunk, small, small chunk, and keep asking you, am I clear? Do you have any questions? So combine these two things always. Am I clear? Do you have any questions? So she'll say, no, no, you are clear. Yes, go ahead. Like that. So keep asking that. Especially in teaching station, you have to keep asking to your junior, am I clear about this? Do you have any questions? Do you want me to repeat anything? So that things you have to inculcate in your talking. That is the most challenging part. But once you have the template, you gradually inculcate that habit. So checking the patient understanding, checking your colleague understanding is very, very important, and you get marks for that. So if you have counseled only 3 treatment option and not the fourth one, it's okay. But if you have done that 3 in right way, you will get the marks and you will pass the station. So that's important. Then at the end, if you get time, which you most of the time don't get, at the end you can summarize. So today we have discussed about these things. Today we have discussed about these treatment option, and you agreed to come up with your what you want to go ahead in 2 weeks time, and you will follow up in 2 weeks time. Is that all right with you? Do you want to add anything like that? So this is how you summarize that this we have done. If you have time at the end, sometimes the station will finish early, so you get marks for this. But summarize always, most of the time you don't get enough time, so it's okay. Even if you have not done, you will not lose marks. So don't worry about whatever you couldn't do. Worry about what you have done in a right way is important. And sometimes at the end you have to give her written information like grade 3 tear, perennial tear grade 3, so you have to give them the leaflet. Anything you have the leaflet, you have to give them. Like in oncology, in CIN, or in consent advice, you have to give them the leaflet. So giving leaflet is very, very important. If you have any written information, you will tell that. Most of the time when I was preparing, I used to remember this leaflet has this name and this, that. And then you don't memorize that when you're vocalizing it. So better not to waste your time in all that. Just tell that I will be providing written information about this for you to go through. And if you have any questions in the next meeting, you can tell me. So that's the best thing. I will, if you know that there is RCOG leaflet like pill, patient information leaflet, you will tell that I will provide you patient information leaflet. If you cannot remember if there is a pill or not, simply say I will be providing written information for the same for you. You can go through, and if you have any questions, we can discuss it later. Like that. So providing written information is important. If you give that, it's a good thing, and you get marks for that, because that's how the patient can go through, because she cannot understand all the things you have communicated in one sitting. So she can go through the written information at her convenience later, and that will be good thing for her to understand things in a better way. Then whenever you are talking to the patient, you don't have to use the medical word. This is the most important challenge. Means they don't say vagina, like they say down below. Down below means perineum, vagina, whatsoever. So water works for bladder, urine problem. Like we ask directly to the patient, do you have any bladder bowel complaints or urine or motion problem? They ask like urine, for urine they ask water works. So these kind of words you have to inculcate in your speaking. And once you read the patient information leaflets, which is available in RCOG site free, you will understand that how to talk to the patient, how to avoid the medical jargon, what is called for the, like for uterus, you have to tell womb. You won't be telling uterus. For tubes, you have to tell, means there are different terminology. So once you follow that terminology, like anything simple, if you can remember, you cannot use the medical word is the most important thing. You cannot use that, and you have to try to simplify it as much as you can, which she can understand. Like a rupture of membrane, you will ask her, did you broke your water? So like that you have to ask how they talk. So as I told you, communication is the key to pass this exam. Communication skills will be tested in 3 domains. One is information gathering, where you are taking the history, communication with the patient, the information gathering, and you are giving them the treatment option, applied knowledge, everything. Everything is communication. Throughout the role play station, you are communicating with the patient. Then the communication with colleague, which sometimes is even safety point. So this is also important. So communication is really, really important, and how to communicate is what is mainly part 3 exam. So what are the good tips of communication? As I told you, good listener. You have to be good listener. Don't speak less, listen more, and the role player will take you to the right direction. Be very empathetic. As I told you, if she's crying, give her tissue. Wait for her to stop crying. If she has labor pains, wait for her to stop labor pains. This is really, really important. Otherwise, no marks. Acknowledge patient emotion. If she is angry, you have to tell, I agree with you. I can see you are very angry. You have to mirror her emotion in a way. Like if she is sad, you have to behave as if you are also sad. If she has undergone through an IUFD miscarriage, you have to also show as if you are sad. So your voice will be very low tone. Don't show a confident voice at that time. They want a friend. They want at that time somebody who can be with them to clear their tears. They don't want a doctor at that time. They want somebody who can just tell them that I'm there for you. So that kind of thing you have to understand. Acknowledging patient emotion is important. Non-verbal communication, like if a patient is crying and you are sitting in your chair, not moving from your chair, you have lost the marks. If a patient is crying, you have to lean forward, right? You have to lean forward, you have to try to console her, touch her if you want, whatever. So non-verbal communication is important. Just sitting doesn't work. Leaning forward sometimes makes a difference. So that's important. Open and close question, as I told you, open question means you just directly ask her that could you tell me more about your problem. Could and would word are very, very important. Could you tell me more about your problem is a open question. And if I tell her that, do you have any fecal incontinence? Do you have any urine incontinence? Do you leak the urine? Or in like in HMB, if I tell, do you have postcoital bleeding, intermenstrual bleeding? These are closed question where the answer come in yes and no. So closed question, try to avoid as much as you can, because closed question in exam will be very difficult. But sometimes you do have to ask. In open question, most of the time she will tell you all the important things which are important for your exam. And if you follow that, it's enough. But if you forgot asking open question, you have made your life more difficult, because now you will ask 10 closed question in place of one answer of open would be enough. So be careful in that situation. If she has not uh, told something which is really, really important and which you want to know, then you can ask this closed question. But most of the time, open questions are enough. And that is your savior basically. In exam you're little bit nervous, and sometimes you will ask haywire silly question and all that. So better just to open your mouth and say, could you tell me more about your problem? And she will tell you all the important things what you need for exam and passing that station. So that will be a better idea. Targeted history. Targeted history means like in urogynecology, there is a different kind of history. In maternal medicine, there is a different kind of history. Like in maternal medicine, you have to ask her about previous history, when she has the last fits, when she had meet her the respective doctor, like cardiac problem, epilepsy problem, when you met your neurologist, when is your last blood test done, when is your last fits episode. So these kind of things you have to ask in maternal medicine only. So medical history in detail in maternal medicine, the same way for urogyne, you have to ask her, are you wetting yourself? Whenever you are taking history of overactive bladder, you have to ask few question of DD also, like SUI, bladder pain syndrome. So that kind of thing, UTI history is important. So that kind of thing is important in urogyne. Like in sexual history is important for sexual uh, station only. So you cannot ask sexual history in detail in all the station. Only in sexual contraception station only you have to ask. So you will tell her that would you mind if I ask you a few personal questions? Are you with someone at the moment? If she usually in sexual history, sometimes there will be 3 4 partners, so she will come up with, I have a male, I have a female. So don't get surprised, because that's why the sexual history is important. So how many partner you had in the last 6 months or 1 year, so you know her risk of STI and all that thing. So it's a big template for sexual history, and believe me, with great struggle I got that. So sexual history has a template which you have to follow. Urogyne history has a template you have to follow. Maternal medicine has a template you have to follow. Otherwise all the history are the basic history. Like in obstetric history is important. In menstrual gynae, menstrual history is important. So you have to understand for this station or this particular module which history I have to take in detail, because if you try to take everything in detail, you cannot finish your history taking in 4 minutes. Ideally, they say for history taking, you have to spend 3 minutes only. Means your question should finish in 3 minutes, and 2 minutes you will keep for the role player to speak. So in 5 minutes, all the things will be finished. And then remaining 5 minutes, you have to counsel the patient about treatment options or whatsoever. So they say the little you speak, the better it is. So don't make it lengthy, because you will keep taking the history and you will finish your time. So it's very important that you time your history and keep practicing it. You can practice it in front of your mirror, or you can practice it with your partner. It's always better to have a partner to practice, because you are talking to somebody, so it gets you a practice. And you always need a partner. For part 3, you have to have a partner, so even you can become partner with each other and practice. But daily you should practice. This is how I did. So I will suggest you daily, if you can do. If you cannot do, you can do once in 2 days or whatsoever, but you have to speak. And you have to speak with somebody. If you don't get a medical partner, it's okay. If you get your sister, any family member of yours is ready to become your role player, or ready to talk to you, it's okay. But you have to talk to somebody. If you practice on your own, nobody's watching you, that is not a right practice, because in exam you have to talk in front of 3 people. So if you're a shy person, it's very, very important that you talk face to face. If you're not very shy person, then also it's very important that online you have a friend and you are every day practicing with her about, you will practice 1 or 2 station and she will practice 1 or 2 station, you will give her feedback like that. So this is how it goes. You have to have a partner to practice this exam, because this is a speaking exam. It's not writing that you have to do it alone. You have to do it with 2 people. So 2 people at least are really, really important. Or if your group of 3 also is good, one will speak, one will listen, and one will give you the feedback. So that is also okay. This is all like, take it light, means it is just practice to enjoy. This is not to get bugged up about anything. Just enjoy practicing this, and so that you have already done enough, and on the day of exam you feel as if you are practicing with your friends, so it becomes easier on you. That is what it means. As I told you, simple explanation to the patient, take breaks, give the information in small bits, be honest to the patient. Be honest means say sorry. As I told you, say sorry, the magic word. Sometimes patient will ask you, what is the percentage of me going into the labor? Supposedly PPROM, she will ask me, what is the chance of me going into the labor? So you don't remember. You remember maybe, or you don't remember maybe. Sometimes in exam, even if you remember, you will not remember. So be prepared with not remember thing. So if you don't remember, and you don't have to memorize the percentage as I told you. So you'll just tell the patient, there is a fixed number of percentage, but I'm sorry, I cannot remember it right now. So I will check the literature and get back to you. Or I'll ask my consultant and get back to you. It's perfectly fine, and you will not get penalized for this. You will not lose any marks for this, but don't tell some absurd percentage like you cannot remember and you say 30%, 40%, as if this is MCQ exam and you have to tick something. No, just tell that I cannot remember and I'm sorry for that. And I would surely ask my consultant and get back to you. I will surely refer the literature and get back to you. That's perfectly fine. So don't bother yourself with these things. This exam is for testing of communication, not testing of your percentage and knowledge. So be honest with the patient is perfectly fine. Sorry, I don't know is saying is perfectly fine. So be honest is what you need. Apologize, as I told you, sorry is a magic word. So keep telling it whenever you feel it is appropriate. Even if it is your mistake or not, you're sorry about the situation, not about your mistake. Okay, so what to study? You have already read the guidelines, so you are already thorough with that. So what you have to read is pills, patient information leaflets. So every module has few patient information leaflet. And because I am a paper person, I printed it all and I read. If you can read it in soft copy, or you want to print your wish. So that way you read how to counsel a patient. In pills, they write in question answer format. Like patient will ask you, what is my percentage of having this? What could be the possibility? What are the treatment options? So it is in question answer format. So you can read it in question answer format. So you understand what type of question patient can ask me from this topic and what I have to answer. And by reading the pills, you understand all the non-medical word for counseling, because in that it is written in the patient words, it is not medical words. So like in guideline you read bladder, here you will read waterworks. So that's how you understand what are non-medical jargon words. So reading pills is the must. You have to read the pills at least 2 3 times, and it's not difficult. It is not like guideline where you have to sit with a quiet mind. Pills you can read anywhere, like paper, like newspaper, like It's not like even article. It is just you know everything, but you're talking to somebody in simpler words. So it's like a it's like a pleasure for the brain because you have done so much intense study. Now you just have to simply read the simple things. But it really gives you a knowledge about what to talk to the patient, what words to you use in what ways. So that way the pills are the key to your communication. That's why pills has to be read, all of them. And it's not difficult, it's not many, so it's easy. Don't worry about that. Some of the recent talks, because sometimes they make a new station from the new thing came in the talk, like sometimes transgender women, sometimes that kind of, you know, difficult station, I may say, will come in the exam. But don't worry, as I told you, if any station you don't know, supposedly, you don't know that station, you have done the information gathering, so you'll get marks for that. You behaved in a polite way, you will get marks for that. Even if I don't know anything about that station, I can score half of the marks by doing other things right in the way I have to do. So if in exam, supposedly you get some station where you don't know anything about that topic, then also don't get stressed up. Just perform it. Just do your routine, your history taking part, and at least you'll get marks for that particular point. And then whatever your applied knowledge for that particular topic, you can tell her. And whatever you don't know, you can say her sorry. So all in all, you get some marks. So if you don't know and you think, oh God, I don't know anything about transgender women, so what I will do today? So I'll fail this station and you will break down. Don't do that. So here in this exam, you have to behave maturely. Don't behave like kids. You're all grown up, you're all professionals, you're already dealing with your patients. So don't behave immaturely in this exam. Behave as if you know anything and everything. You are a clinical practitioner, you know everything. Yes, you don't know anything, but nobody in this world know everything. So you can say sorry to the patient. You can tell that I will see the literature and come back to you. That's totally fine and acceptable. Or always your savior is consultant. I'll discuss with my consultant and get back to you. Best. So these are the things you have to, as I told you, this exam not difficult because people who don't know all these things, how to handle and tackle these difficult things, they sometimes break in the exam, and that's how they are not able to do as they could in the exam by simple tips and tricks. So it's important that you understand how to handle difficult situation, because if some new talk or new question has come, it is new for everybody. As I told you in part 2 also, do easy things right is key to success. Don't make silly mistake is key to success, rather than doing one or two hard questions correct, because hard is hard for everybody, and this is a norm based exam. So if some question you find difficult, some station you find difficult, everybody is finding that difficult. So don't panic. Don't panic and try to handle it, and at least you will score something rather than losing all the marks. Books, there are only few books, and it is not intense book like part 2 where there are many and there are many AMQs and SBAs. The books are very simple, simple to read, simple to understand, and they will be telling you about all the domains, how the questions are for. So you get some question in the book to practice with your friend, your partner. So these are the books. Justin Conje is the recent book 2021. Then this one. All book are good, and whatever possible book you get, you can practice. And there's nothing like this book is important and this is less important, because already there are only handful of books. So whatever books you have, you should practice it, and you should try to. Anyways, I have posted this in the Telegram group. So all the material I will keep posting. The books we have already posted, pills we have posted, and I will keep posting further. So that way it will help you in your preparation. But books are not intense, so don't worry by seeing the thickness of the book, whatever thick it is. But most of the things you already know. It is just for practice and getting few questions to practice. Do you have any questions about what to study in this slide particularly? Do you have any questions? Anyone has any questions about, out of all 15? Yes, Dr. Sara, Dr. Bhakti, Dr. Rabia, these are some new names for me. Do you have any questions? I should have asked after every slide, do you have any questions? But that it would have become very long. So that's why I'm asking now. Till now, whatever I told, do you have any doubt, any questions you want to ask me? anything it's not clear
It's clear,
and you
ma'am.
want me to? Very good. Okay, so as I told you, you all are already the champions. You all are already the winner. So you don't have to be afraid. Only go and grab it now. It is that is what left. Okay, so this is what you have to do. And as I told you, no panic. We are all professionals and we can handle it. So in history taking, today we are talking about history taking. Why we are talking about this? Because yes, this is the first step. This is the first step to MRCOG part 3. This is the first step for all the module. First, I thought that I will put labor ward prioritization, the most difficult station. Most of the students find it difficult. Even I found it difficult at my time, but gradually I got a hang of it. Then it is easier. Then I thought, no, I cannot do this. The students will be really afraid. So first I should give you the basic how to take a history. And soon I will be doing the labor ward prioritization in the YouTube. Don't worry about that. So history taking is your first and foremost step in 10 stations because 4 will be structure viva. So in that 10 station, first of all, you will introduce yourself, set the agenda, ask about patient concerns, if any, and then you will ask her, could you tell me more about your problem? The golden sentence, the open question. And she will open up with all the important things. And if you feel something is missing, you will ask a closed question, but most of the time it is not required. Keep that in mind. Don't be extra cautious because you have to finish the station. So allow the role player to direct you and follow the role player is the key. So you have asked her, could you tell me more about your problem? And she will tell you. Then supposedly if this is a patient, twin pregnancy supposedly, she will, if she say that I'm here because I'm pregnant, I'm trying and all that, what you will tell? Oh, congratulations. So this oh is very, very important. Don't say congratulations. No marks for that. Oh, congratulations. Oh, many congratulations. So that exclamation, that happiness you have to show. Okay, congratulations. She'll be saying thank you. And then you will ask her, okay, so in which weeks of pregnancy you are? So most of the time they know the weeks, or even if you ask her month, it's okay. So that's how you will start your communication. Then obstetric history, you will ask her, okay, so when is your last period date? So she'll tell you. If an ops patient, you will ask like that. That becomes a part of menstrual history also in cases of ops patient, because LMP and EDD is what you want to know. And then you will tell her, can you tell me more about your periods? If it is an early pregnancy, because you want to time the pregnancy, right? So if her periods are irregular, she says, I'm PCOD and I'm not sure of my dates and this, that. So it's important that you ask her, can you tell me more about your period? If she says it is regular, so story finish. If she says it is irregular, then you have to tell her that we will be doing the dating scan and then only we will be able to tell you the EDD. So it's a simple thing what we do in our clinic only, but you have to do it in an organized way. For ops history, then you have to ask her, okay, have you been pregnant before? You will not ask her how many children you have. That's an offending sentence. Why? Because sometimes she might be having 2, 3 miscarriages. She has no live issue. So that will be offending her. So you will ask her, have you been pregnant before? She'll tell you, yes, 2 times I got pregnant. And okay, supposedly, if she says 2 times I was pregnant and she stopped, then you will tell, could you tell me more about the pregnancies? Rather than asking her, okay, so what happened in the first pregnancy? What happened in the second pregnancy? This way you can shorten your history taking, because if you keep doing the open question, your history taking will be shorter and the right information you will get. So if you tell her, could you tell me more about your pregnancies? So she'll tell, I had 2 miscarriages, it was DNC or not, and this, that, everything, whatever required, she will tell you because she's instructed like that. So it's not a real patient. She's instructed and she has the script which she has to follow. So allow her to speak is what the right way of doing the history, and quicker history basically, so that you get time to counsel. So, okay, obstetric history, you have finished. Then you asked her about menstrual history. If it is a gynae patient, you have to take the gynae history in detail. If it is the ops patient, you have to take ops history in detail because you know you want to know how much gravida para. In gynae, you want to know how is her period because she's for that complaint. Then, if she's a planned or unplanned pregnancy, accordingly, you have to ask her about contraception. If she says it was an unplanned pregnancy, then the contraception become more important. Were you using any contraception? Why you have to use, if it is an unplanned pregnancy and it is contraception failure, maybe this is an MTP station. Counseling of MTP, rather than giving her antenatal care advice, you have to give her MTP advice. So be careful. That's why if unplanned pregnancy, it should alarm in your mind that I have to ask, did you use any contraception? Are you happy continuing the pregnancy? Whenever she says unplanned pregnancy, you have to ask her, are you happy continuing the pregnancy? If she says no, it's okay. You can tell her the MTP options. So that's how you decide which station it is. And if you tell her, okay, I will start you on folic acid and then we will be doing, you will tell her full antenatal advice, then we will be doing you screening for Down syndrome, then we will be doing T5 scan for you. Then because there is risk of IUGR, I will be doing scan for you, and then the delivery will be normal. We'll try to aim for normal delivery. In postnatal, we will be giving you breastfeeding advice, contraception advice, all gone in vain. Why? Because this was an MTP station due to unplanned pregnancy, isn't it? So listen the word of role player very carefully and accordingly interpret in your mind what they're trying to tell you, and then you have to accordingly advise them. So unplanned pregnancy means contraception is important, and accordingly you have to counsel her about MTP. Unplanned pregnancy means asking her, are you happy to continue pregnancy is important, because this is what you will do. Anybody coming to your clinic telling this is an unplanned pregnancy, what you will tell, are you happy to continue this, right? Because accordingly you have to counsel her. So take all that words, the cues, seriously. Then you will ask about the cervical smear. Mostly it will be important in gynae station, in oncology station, old women and all that. For pregnant women, even if you don't ask for cervical smear, it's acceptable. So putting a word is important. Like what happened when we go in exam, I'll tell you why everybody feels so stressed up about preparing part 3 is they try to accommodate each and everything in each history, each module, which is practically not relevant and practically not possible, because in ops history in a pregnant patient, your time goes in ops history too much sometime. So if you ask her about contraception, if she's pregnant now, if she's a pregnant and it's a planned pregnancy, no point in asking her, were you using any contraception? This is a silly question. So no point in asking her that. Is your cervical up to date for a pregnant patient is important, but even if she has not done, you cannot do it now. So yes, putting a word is important, but even if you forgot for that, you will not lose marks for that, or you will not fail that station. So allow yourself to be natural, how you deal with any patient. Like any pregnant patient, what you deal with, you ask her, is it your first pregnancy or what? Can you tell me more about your previous pregnancy? Have you been ever pregnant before? So ops history is what you take significantly. You take her LMP ED because you have to date her pregnancy. These are important rather than contraception and smear. So be careful how you behave with your patient, the same way you have to behave in the exam. And if you behave in the same way and forget some silly things, it doesn't matter. So don't stress too much for that. Then you will ask her about medical and surgical history, which is important. Medical history, do you have any medical problem of concern? So she will tell you if she has any medical problem. She will let you know about if she's taking any medication. So somebody mic is on. So you will ask her like that. Do you have any medical problem of concern? Do you have you undergone any previous surgeries? So that way you can ask, because if she is a ops patient, she might have undergone previous cesarean, anything can happen. So always just putting a word for medical and surgical illness is a good idea, because sometimes there might be something hidden there. She might be epilepsy in pregnancy. She was not aware, not taken any treatment. She might be previous cesarean, previous laparotomy for rupture uterus or whatsoever. So medical and surgical is always important, and you shouldn't miss it in any module or in any scenario. Just putting in a word for this is important. Drug allergy in obstetric, very, very important, because if she has allergic to any drug, you cannot give her antibiotic if she rupture her membrane for GI GBS, for PPROM, for whatsoever. So drug allergy is always important. Family history is always important, even in obs, even in gynae, because in family history you can ask, like in obstetric, you can ask if you have any family history of concern. No need of asking, do you have family history of preeclampsia, diabetes, these, that? No. Family history of concern is enough. This will save your time. Do you have any medical history of concern? Do you have any family history of concern? She will tell you the right thing. Don't ask 100 things possible in family history, because these are not important questions. Important questions are here in her present complaints, in her obstetric and gynae history according to the module. In maternal medicine, medical history and drug history become important. In maternal medicine, once your first step will be, you will be asking her, okay, how good is your control of epilepsy? When you met your neurologist, have you done any recent test? Have you had any recent fit? At the same time, you will tell her, do you have any other medical problem? Are you taking any other drugs? So it will cover there in one sentence. No need of asking it separately later. So that's the difference. That's how you change your history according to your module. So history is same. History is these many points only. Only few history become important for some particular module, and few points become unimportant. Like for a planned pregnancy, contraception become unimportant. For sexual and gynae, cervical smear become very important. Ops history become unimportant. For oncology, family history of cancer become important. So the format is same, but you have to emphasize different thing according to different module. Then comes the social history. Social history is very important because here sometimes they are not having partners, they are single and things like that. So you always have to ask, if you don't mind, can I ask you few personal questions? Or would you mind me asking you a few personal questions? It could be in two ways, it could be in many ways. So you have to find your own sentence if you like, or if you want to inculcate my sentence, it's more than welcome. So it's accordingly what suits to your tongue. There's no fixed sentence, there's no fixed sentence which is right and wrong. Or even if sometime in stress you forget to tell, can I ask you a few personal questions, and you directly ask her, do you smoke, do you take alcohol? They are not going to penalize you for that because it's very common here. So yes, you have to be polite, and before entering in her addiction history, you should ask her, do you mind me asking you a few personal questions? If you take that, good. But believe me, even if you forget about this, they are not going to penalize. So mm, don't stress up yourself is what most important thing. Keep practicing so that before exam your set format is already ready and the words automatically come out of your mouth. But in exam stress, even if you forget one simple silly thing, it's okay, acceptable. Then you will ask that, are you with someone at the moment? She'll say, yes, I have a partner or whatsoever. So, okay, is he supportive, especially in pregnancy? Is he supportive? She'll say, yes, he's very supportive. There's that. Oh, that's good to hear. So you have to show happiness that she has a support system with her. So don't say, okay. Okay is a very rude thing. Oh, happy to hear that. Oh, great to hear that. Oh, good. Oh, that's nice. This kind of exclamation is helpful when you listen to the history, because here people are very expressive. So they don't stop with okay, or they don't stop with the nod. They are always like, oh, lovely, great, perfect. These are the common words you will keep listening every other second here. So try to inculcate that when you're listening to somebody. Then you will ask the drug history, which is important. Then at the end, you will ask about the woolly questions, especially in cases of pregnancy. You have to ask about the depression. Again, you have to take her permission. Do you mind if I ask you a few personal questions? Do you mind me if I ask, have you feel depressed or anxious in last 1 month? Have you feel loss of pleasure in the last 1 month? Like that. So that kind of really questions, not always, mainly in antenatal maternal medicine sometime, otherwise not always. So it's not a must, but sometime like domestic violence questions, that type of questions you have to ask. If they give you the cue like she's not attending regularly her antenatal checkups, so they are giving you a cue that it could be a domestic violence. So then you have to focus yourself here rather than in these kind of history. So as I told you, different module or different station want you to focus on one aspect of history. Not all module want you to take all the history vaguely and superficially. You have to take one or two in the depth according to the module. So you have to modulate your history taking according to the scenario and station given to you. Am I clear about how to you have to take targeted history and change your history pattern and focus according to the module? Clear, all of you? Okay, great. Okay, so how to organize yourself? As I told you, you have to first of all find a partner. That's the best way of doing it. So find a partner. It could be a medico, non-medico, your nurses, your workplace, anybody, whoever agree for your listening to you for 10 minutes, 15 minutes is your study buddy. So study with your partner. Choose a course because you have to have some guidance about this, that what you have to speak, what not, so it become easier. So it's not like you cannot pass the exam without a course. You can, but it might take little longer time. Maybe the path will be more stressful, more anxious, more longer, but it's not like it's a must, but it makes your life easier. And you can depend on somebody, you can take guidance, so we can help each other. Like that, the course can help. How many courses to take? There's no fixed number. Some people take one course, some people even take two, or some will take no course. So that's all acceptable. But I will tell you, at least you should take two courses. One course for your routine preparation from the beginning till end, all the stations and module and all that. And one course at the end for the circuit. When you prepare, you should practice at least one circuit. If it is physical, very good, because that will be like I have attended in that non-RCOG franchisee in Delhi. So it was a circuit. There are people, there are different people, different role players. So they have given it like a mock, like exam, like scenario. So that gives you a practice that how that fear of exam goes. The fear of exam goes, and you know that you can handle it like that. For me, it was other way around. I gave the mock, and I felt as if they were not up to the mark. Means they should have been little kind on us. They were not the actual replica of RCOG. So they were like hari kari bari, and they were like little harsher is what I felt, and the examiners were also somewhere very rude. So it's not the actual replica. So don't get depressed. So for me, actually, after exam, I felt that I don't know anything. But it's not like that. Take the circuit and take it light on yourself. Sometimes it is not the actual replication of RCOG, but it is the actual replication of how to stand 2 minutes outside the cubicle, go inside and 10-minute perform. So you are your best critic. Don't take the teacher who is commenting too much seriously, because they are different. What mindset they are doing, we don't know. So my advice is the last circuit what you take before exam. If you are taking physical one, good. If you are not getting any physical one, you couldn't get a place or whatsoever, then even the virtual online one is also fine. At the end, you should have the courage to stand in the exam and perform is what matters. So everybody is different. Maybe you
Ma'am,
don't
I
need
have few
any
questions.
course,
Shall I
or
please?
maybe you need more. So you have to decide according to your personality and your need that what suits you. So there is no fixed guideline for that. So once you feel you're confident, it's fine. You can go ahead with the exam. So that's the important point, that you are the best judge for yourself. But finding a study partner is a must, as I told you. Without that, it's difficult because this is a practice exam and speaking exam. So you should speak, 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 keep speaking. And if somebody is there listening for you and giving you feedback, that is better rather than speaking in front of mirror, because then you're very comfortable. You're talking to your own self. That doesn't make sense. So better to talk to somebody, practice with somebody, two station you practice, two they will practice. So in a way, it's a good way of preparing for the exam. Okay, so key points to succeed, as I told you, be positive, very, very important. Right preparation with set
Ma'am,
timelines,
excuse
because if
me.
you keep practicing, you have to set timelines, otherwise it will never finish, isn't it? If you think, okay, when I will be ready, I will give the exam, then the day will never come. So you have to set the timelines for yourself. that by this time I'm going to give the exam, so that you can make your timetable and start preparing, which is important. So set your timelines, and then you will be able to prepare by that time. Listen to the role player. Most important tip is listen to the role player. They take you in the right direction. Be calm and confident. You are a medical practitioner. Don't think you are a student. Think that you are a doctor and in front of you is the patient. Think that that patient is for real. Don't think that is a role player. And how you behave in front of your patient, the same natural thing will come out. So whatever way you mold yourself by practicing and all, the acting and all, little bit you will be able to perform. And the remaining, whatever you do with your patient will come out. So don't worry about if you are natural in exam. You will be able to practice and perform in your exam. So try to change your own self. If you're practicing in clinic, try to practice breaking bad news in front of your own patient. So sad. And she miscarriage breaking bad news to my one of my patient when I was preparing. And the patient was like, isn't she becoming so over sympathetic like that? But that's okay. At least I got the practice. So try to change yourself in your clinic, and that will be the best way of practicing things. And as I told you, if you are natural in exam, you will pass. So try to be natural, try to behave as the role player patient, then you will pass the exam. So being calm is the key, being confident and composed is the key. Taking the non-verbal cue is the key. Your behavior is the key. How you sit, how you talk, how polite you are is the key. So these are the things which are tested in the part 3 exams. So as empathetic you are, as caring you are to the patient, you succeed the exam. So don't worry about if you don't know the medical thing about that. Like if I got a station of spinal cord injury for maternal medicine, half of the thing I don't know if I remember the template or not. Even I cannot remember. I gave 3 years back, but the only thing came in my mind with spinal cord injury was the clotting, isn't it? Clot. So clot thing and the pressure source and these things, 2 3 things only came in my mind, and I spoke that. And 5 minutes history taking and 5 minutes remaining, whatever 2 3 things, the gross things you can remember about that station, if you cover that well, it's enough. And if something is missing, role player will help you. So don't get too much depth of things. You only have to remember through 2 3 4 5 things for one station to counsel the patient and put it in a nice way, non-medical way, non-jargon way, and you pass the station. So this is how your goal should be. So it become easier. Practice is very important, and practice is the key to success. And as I told you, it's easier than part 2, and you have done the part 2. So pat your back and you're ready. Practice, 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 because practice makes you perfect and it is a verbal exam. So practice it. But real practice is with patients. So if you are in a clinical job, you can simply practice it with your patient. But the RCOG acting thing means the little bit of acting part is there, and the same template you have to follow. You cannot do that with your patient. So that template thing to practice, you have to have a partner to tell them, and they will be listening to you and giving you feedback how they felt is enough. Not for the medical thing, for the kindness, for the empathy, how much you could satisfy them is what makes the difference. Okay, so this is the standard course starting in August, and the fee is £600, but the early bird till August end is £399. But the good news is for our own students, AMMRCOG students, it is 50% off, so they can join for £300. The another good news is whoever is attending today can also avail this 50% off for next 48 hours. So I'm here to help you all if you need help, or I guided you how to prepare if you can do on your own. That is also good news. So whatever way you choose, but prepare it and give the exam with confidence is what matters the most. Why us? Because we all, as I always say, we teach in small group and we are like family. So we are approachable. You get the right material in a right way. So it's easier to grasp and remember. You get a personalized care one-to-one. I'm always available. You can ask my students. 24/7 I'm available. As you all know, that is what my passion is, and I try to manage it. And constant motivation is the key, and I always keep stimulating you people, that in part 2 also every day I'm stimulating you, and for part 3 also it will be same. So that way you keep practicing and you finally come out with the, sometimes you might think that she's pushing us so much. Is it really required? But believe me, motivation makes a difference because we are busy with our own self. It's very difficult to keep motivated every day for exam when we have kids, when we have family, we have practice. Some days are bad. So it's really a boon to have somebody to motivate you. Yes, my dear Maria, that's true. So start with us, achieve with us, and become a part of MMRCOG family and get your degree and heart. The convocation day is really, you feel like a queen as if you have achieved and your hard work all is worth. Because when you walk in the convocation, you really feel proud of yourself and your family also feel proud of yourself. So that's really something to relish whole life. Okay, so join us as your success is our goal and together we can make a difference. So we can join hands and we can make things happen. Any questions anybody has?
Ma'am, I have a question. Shall I
I'll take it as
proceed?
yes.
Ma'am, regarding the history in the information gathering pertaining to the patients who are antenatal mothers, till what week of gestation we can ask about the last menstrual period and the menstrual history concerns, ma'am? Because if patient is presenting at 32 weeks of pregnancy with some concerns, she
I
has
couldn't
attended the
hear you, my
antenatal.
dear. I think some connection error. Can you speak again?
Yes, ma'am. Can you hear me
Pagalu,
now?
can you speak it again, my dear? Because I couldn't listen to it.
Yes, ma'am. Yes, ma'am. I'll repeat. Can you
Can you
hear
tell
me
again?
now?
Yeah, please.
Yes,
Yeah,
ma'am.
I
Ma'am,
can hear you
regarding the
in broken
antenatal
voice.
mother.
Yes, can you tell me? Yes.
Yeah, ma'am. Ma'am, if an antenatal mother comes in the late trimester, that is in the last 3 months of the pregnancy with some concerns, do we need to ask about any history related to the concerns related with the menstrual history and last menstrual period or not?
As I understand, you are asking me if an antenatal mother come in the last trimester, do we have to take the menstrual
Yes,
history?
ma'am.
Is it your question, my dear?
Yes, yes, ma'am. Is it required?
No, if
Yeah.
supposedly if they have given you the scan, supposedly if they have given you that she's 32 weeks pregnant, or supposedly sometimes they give you VBAC counseling. So 28 weeks and she came to you for VBAC counseling, or 36 weeks
Yeah,
twin
ma'am.
pregnancy, 32 weeks and they sent you for counseling for delivery mode. Case, even if you don't ask her what is your last menstrual period, it's all right.
Yes,
As I
ma'am.
told you, according to the scenario, you have to mold the history and
It's
nobody
all
will
right.
penalize you for that. Because if you will ask the menstrual history, it doesn't make a sense because they have already
Okay.
given you, she's 32 weeks. And once you tell her, can you
Yeah,
tell me more
ma'am.
about your problem? Or as I understand, you are here for the counseling for the delivery, what mode of delivery. And I can understand you are in your 32. You have to revise what you got from the information outside the cubicle. So what
Okay,
you will
ma'am.
tell, okay,
Okay.
so as I can understand that you are 32 weeks pregnant and you have come here to get the counseling about the mode of delivery. Am I right? Is that correct? Do you want to
Yes,
add
ma'am.
anything like that? If you tell, if she's a wrong date or something, she will tell them. So do you want to add anything, or am I right? If you allow her to speak, she will tell you. So in that case, you don't have to ask her, okay, so what is your last
Yes,
menstrual
ma'am.
period? This
Got
is
it, ma'am.
crazy. If you already told her that you are 32 weeks pregnant,
Yes, ma'am.
given to
Yeah, ma'am.
you, and you told her, do you want to add anything? And she told, no, you're right. Am I correct? If you ask her and she says, okay, you're correct. In that scenario, if you ask her what is your LMP, it doesn't make sense. So LMP, asking the LMP
Okay,
EDD is
ma'am.
mainly in early pregnancy when you want to date the pregnancy. If they have
Okay,
given you
ma'am.
the dating scan or they have given you the anomaly scan, already the dating has been done. So no point in asking her
Okay.
LMP. It's okay, acceptable.
Okay, ma'am. Thank you, ma'am.
So
And
that's how
second
you
question,
save your
ma'am.
time.
Yes, ma'am. And shall I go? Shall I ask one more question, please?
Yeah, yeah.
Ma'am, as you said that sometimes the antenatal early pregnancy case may not be coming to know about their birth plan. Sometimes they may have come for to know about their termination of pregnancy. When we are not specific about what agenda the patient has come, can we ask simply one question to the patient that, may I know your specific concerns in this consultation you're expecting from us? Is that okay for them? Can we ask these type of questions?
I'm sorry, because it is your voice is too much breaking. I didn't get. I understood that you told me if the patient has early pregnancy and she want to know about,
Hello?
she's unhappy unplanned pregnancy, MTP, if you want to
Yes,
counsel her
ma'am.
about MTP, you have to, if you can type your question, that will be better. What I understood is whenever you want to give any information to the patient, like if you want to give her the
Ma'am.
MTP option, maybe she's not ready
Okay.
to listen that. So always you have to ask her, do
Okay.
you want me to tell you about the termination of pregnancy?
Okay, ma'am.
She might be ready to continue the pregnancy. She will tell, okay, I will think about it and I will let you know later. So then your story finish. So always ask
Yes,
before telling
ma'am.
too much. Keep asking. Is that all right? Shall I move ahead?
Okay.
Shall I give you all more information?
Okay.
Is that enough? So that way the role player will guide you. If you ask her, do you want me to tell
Okay,
about
ma'am.
MTP options? And she says no, that means this is not an MTP counseling station. So you get the clarity. So always ask
Yes.
her, do you want me to do
Okay,
this?
ma'am.
And if she says no, means this is not
Okay,
that
ma'am.
station. So you get clarity. So always, whenever you
Okay,
have
ma'am.
doubt, what to do, what not to
Ma'am.
do, ask the role player. Do you want me to do this? Even when you are counseling about any treatment option, always tell you, ask the women, do you want me to tell you about all
Okay.
the options? Is that all right if I tell you all the options available to you? Always ask the question and get her agreement before talking too much. And in between, always
Okay.
stop and ask, am I clear? Do you have any questions? So that way she will direct you
Yes,
in the
ma'am.
right direction. If you are going too much about one topic and you stop and ask her, am I clear? Do you have any questions? She will take you in right direction if you are lost.
Yes, ma'am.
So always ask, ask, and ask. Before talking too much, take a pause and ask the role player. So that way she will guide you in the right direction. This is the key, basically. This is very, very important.
Okay,
Don't
ma'am.
keep telling.
Okay, ma'am.
Yes, are you
And
happy
ma'am,
continuing this pregnancy? Or, yes, this is always in unplanned pregnancy, you have to ask, are you happy continuing with this pregnancy?
okay.
So she will tell. So, yes, anyway, as I told you, there are 100 ways of communication. Whatever sentence suits you, whatever come out of your mouth spontaneously without breaks, where, ouch, because this is not an English exam. This is
Okay, ma'am.
a verbal cue exam. How fluent you are, even if you say one is, was, what, tense wrong, it doesn't matter. You should be fluent and your
Okay,
message should
ma'am.
be communicated. So don't worry about all these things. Whatever come
Okay.
naturally of your mouth, let it come out. Rather than saying, if I say supposedly the right sentences, what would you like me to call you? If what would you like me to
Okay.
call you doesn't suit your tongue, you can say, how would you like me to address you? So there could be different sentences. Whichever suits you, you can pick up. Whichever come out easily of your mouth, you can pick up. All are right. Little bit grammatical mistake is acceptable. So don't think this is not an English exam. Before going to UK, you have to pass one English exam also, which is OET. So don't worry, that is coming. That is on page. So this is only the exam
Okay.
of communication, of right communication to the patient. So little grammatical error is acceptable. So don't worry for that.
Okay,
Only
ma'am.
whatever come out
Thank
of
you,
your mouth
ma'am.
smoothly, fluently, you follow that sentence is fine.
Ma'am, sometimes in the clinical knowledge part, sometimes out of stress or tension, if we miss the track and we make out ourselves in the exam that we missed the track and we want to correct it right at the time, how can we approach it, ma'am?
No problem. You can say, sorry, I told too much about this. There are few other options. Do you want me to go through that?
Okay. So no need to tell that I did mistake, I made wrong in the explaining you like that.
Don't say I made wrong. What wrong you have made? You have not done anything wrong. Only you explained
Okay.
something too much and you didn't explain other things, isn't it? Or if
Okay.
you have
Yeah,
made a
ma'am.
mistake, you can always say, sorry, I confused this with that. This is not right for
Okay.
you. Maybe this is a better idea for you. Or I'm sorry, I
Okay.
got confused. I will confirm it with my consultant and get back. That is also a savior. So whenever you think
No.
you have done anything wrong, sorry, by mistake I told you this, but the more appropriate choice for you will be this. And definitely I will confirm with my consultant, and she will also talk to you like that.
Okay, ma'am.
So
Okay, ma'am.
that
Got
way
it.
you can cover up whenever, because if you have made the mistake, the patient will lose faith on you. So you have to always give another person reference that they will also come and talk to you
Yes,
to make it more clearer to you.
okay, ma'am.
Sorry, I made a mistake. Maybe this is not the right thing for you. So I would confirm, or this is better according to our discussion. And I got carried away. Sorry, I got carried away. I got confused with some other patient or whatever. If it is really a mistake, which will usually not happen because you are very focused and you are seeing only that patient. But if it happens, you can always cover up with saying that I will also tell the consultant to talk to you if you feel like, to gain her
No,
confidence again. So that's also
sure.
acceptable.
Thank you, ma'am. Thank you so
The
much.
your sole goal is satisfy your patient. This is what you should remember.
Yes, ma'am.
If
I
you
got it.
satisfy your
Yeah, yeah.
patient,
Thank you.
you're polite enough, she's happy enough at the end, you're done. You have done a good job. So making a mistake is allowed as far as you can cover it up.
No, okay, ma'am. Thank you, ma'am.
Okay, dear. Okay, so that's it. I hope once you practice more, you will have more doubts. You all know about this is the Facebook, Telegram. In Telegram, all 1 to 3 group is there. Facebook, YouTube channel is there where I keep motivating you all and keep
Hello.
posting things. These are all the free group for all the three parts of MRCOG, free groups for guidance. If any query, you can always approach me on this number. This is my Gmail and this is my number. You can always check in website for the recent updates, if any. Okay, thank you. I hope I made your understanding about starting easy. And definitely you all will soon succeed. And some of you might choose even teaching. And some of you will relocate to UK and we can meet also. So it will go on and on and on.
Hello.
Yes, my dear.
Good evening, ma'am.
Good
Uh,
evening.
I I wanted to ask that this course of your which you are talking about August. So is this for the November exam or it or like how long is it? Because I did not attend the full session. So or is it for the May
Uh,
exam?
this course we are starting is for November now, but the students who are starting now for February, if they want to attempt, they will what do you say? For we will have all the material with them, and we will be they can be part of the next course, which will be the revision session as a listener. So this is for active participation, active participants who will be practicing. So like if you take the course and you take as an active participants, and then in the next session you can attempt as a listener. Or because I suggest you to take the guidance even if you're planning to give the exam in February, it's better to start from now, because the more orientation you have, the more practice you do, the more confident you will be at the end. So we will be not leaving you till February exam. You will be part with us. But if you want, you can take it as an active participants now, and later you can be just part of the group as a listener.
And the next exam will be in February or is it in May? Because the calendar is not yet. I am not very sure about
Yes,
it.
usually it is. Usually it is in February, but as you told, the calendar is not yet there, so we don't know. But usually it is in February.
But definitely, if I do not join this time, you'll have another course for February in some time later.
Yes, hopefully I will be having it, because once we start, it keeps going, growing. So that will be there. But as I told you, my suggestion is to start early rather than late. Yes, if you have some commitment and you don't give exam also, that particular time period you will not practice, that's fine. But at least you know things, you start preparing, you get
Mm.
more time to prepare basically.
Okay.
So that way
Yeah.
it makes you more confident. There's no harm in becoming more practice and more confident rather than because if you don't practice for 3 months and you lose touch, then you will
Yes.
find it more difficult to start, and then you will feel that even I forgot what I read in part 2. So keep seeing
Hmm.
things, keep practicing is easier rather than losing the track. Because I also didn't give my part 3 immediately after part 2, because I delivered at that time. But I started preparing immediately, and then I kept in touch with my friends. My friend gave it early who were practicing with me, and I gave after them 2 3 months. I got another partner like that. But at least I didn't lose the touch, so the confidence was still on. So that's how is my suggestion.
Yeah, because my condition is somewhat the same, so I'm asking.
Yeah, I can understand, Akriti, but it's your choice. Even
Okay.
you are part of group and you can practice in group. If you want to take a break for full 3 months, it's okay. But
Hmm.
as I did, I'm suggesting that please be in touch.
Yes, yes.
Don't lose it completely, and then later you find it difficult as if you're starting from the beginning. So be part of things. Even if you are not giving the exam, at least start practicing. Find a partner who is
Hmm.
preparing for February and start practicing slowly. So that is also a good idea. The more you practice, the easier it is. So find a partner who is also giving the, not this one, next one. So you can go slow
Hmm.
on yourself, but at least do the things, start the things, do it in right way from now itself.
Okay. Thank you so much, ma'am.
Okay, take care. Take care, all of you. I'll edit this session recording, some work come up. Yes, my dear, it will be there in the YouTube channel. You can listen to the recording whenever you get time. Okay.